Hello everybody, welcome to postgraduate class in obstetrics and gynecology, and today's topic is magnesium sulfate in pregnancy. Magnesium sulfate is most commonly used drug in obstetric emergencies. It has drastically improved patient management in eclampsia. Residents should know the pharmacology of this drug. It is a frequently asked drug in table viva. Indications for the use of magnesium sulfate in obstetrics are to prevent further convulsions in patients of eclampsia, that is, it is a therapeutic indication. Preventive indication is maternal neuroprophylaxis in patients of severe preeclampsia, where we want to prevent occurrence of convulsions. As a fetal neuroprotector in preterm labor is the current emergent indication in the last recent few years. And as a short-term tocolysis in preterm labor is a questionable indicator because there are better tocolytics are available for this indication. Now, as you can see, a 2 ml vial is there. It contains 50% of magnesium sulfate, and whenever it contains 50%, this 2 ml vial or ampule has 1 gram of magnesium sulfate. Now, this is a commonly committed mistake by the postgraduate students also, not only PGs, UGs, not only undergraduates, but sometimes postgraduates also, that they say milligram. Now, remember that always magnesium sulfate comes in grams, and that is why you should be using the correct terminology. So it is 1 gram in 2 ml, or in other words, it is 0.5 gram per ml. Main contraindication for the use of this drug is myasthenia gravis. Now, action of magnesium sulfate, what we should remember is it is not an antihypertensive. It doesn't act as an antihypertensive. Whenever we are using magnesium sulfate in patients of hypertension in pregnancy, we need to use antihypertensives separately. It has a specific anticonvulsion action, which is mainly the direct action on cerebral cortex. It leads to nausea and flushing for initial 15 minutes. Transiently, it reduces the blood pressure by reducing the systemic vascular resistance and mean arterial pressure. And there is an increase in cardiac output, but this action is only lasting for 15 minutes. So it is a transient action. It leads to uterine muscle relaxation with a higher dose when the level of the serum magnesium is 8 to 10 milliequivalent per liter. At higher level as compared to the anticonvulsant level, it leads to the relaxation of the uterine muscle. Now, the most important trial which was conducted for the use of magnesium sulfate to prevent occurrence of convulsions in patients of severe hypertension in pregnancy. That trial is called as MACPI trial 2002. It was conducted in the year 2002. 10,000 women from 33 countries were included in this trial. Patients with severe preeclampsia requiring termination of pregnancy were included in the trial. Magnesium sulfate was given and it was studied as its effect was studied with comparing it with the placebo. Now, what was found was not only there was a significant reduction in the occurrence of eclampsia, statistically significant reduction in occurrence of eclampsia, but also there was a reduction in placental abruption and overall maternal mortality. So all these three are most important for us as obstetricians, and that is why this is a path-breaking trial. Whenever we talk about the use of magnesium sulfate in patients of severe hypertension in pregnancy, we should always be mentioning this MACPI trial 2002. This is just a revision. We have already seen what are the features of severe hypertension in pregnancy. Now, whenever I say hypertension in pregnancy for postgraduates, what you should remember is it includes patients not only of preeclampsia, but also of gestational hypertension and chronic hypertension. So it is an umbrella terminology, severe. Whatever is the category of hypertensive disease in pregnancy, any of these features is indicative that disease is entering into the severe category. And out of these, most important for us, apart from blood pressure, are whether it is early onset, whether there is associated intrauterine growth restriction, oliguria, upper pain, and all these features which are suggestive of severe preeclampsia, suggestive of patient going for preeclampsia, such as headache, visual disturbances, thrombocytopenia, increasing creatinine level, increase in serum transaminases suggestive of hepatic dysfunction and occurrence of pulmonary edema. So all these features should be at the tip of the tongue for postgraduates, so that whenever you are examining a patient, you find any one of these features, it indicates that there is a severe hypertension in pregnancy. And MACPI trial, the inclusion was patients having severe hypertension in pregnancy, requiring necessitating the termination of pregnancy. How do you administer Maxel? It can be administered in 3 ways. First is intravenous continuous infusion. Second is intramuscular intermittent injections. Though these are painful injections, these are still being used in the low resource settings because of the non-availability of infusion pumps to use the continuous intravenous infusion, or it can be given as intravenous intermittent injection. Now, in patients of eclampsia or severe preeclampsia or severe hypertension in pregnancy, whenever we are giving magnesium sulfate as continuous intravenous administration, how it is given is loading dose is given 4 to 6 grams in 100 ml of IV fluid, and it should be given over 15 to 20 minutes. Maintenance dose is either by giving 2 gram per hour in 100 ml IV infusion or 1 gram per hour in 100 ml IV infusion. If it is given as 1 gram per hour, it is called as Zuspan regime. If you are asked what is Zuspan regime is, where you give the loading dose and maintenance dose is 1 gram per hour. You continue this for 24 hours after delivery or after the last conversion, whichever is later. Now, whenever we want to give this continuous IV infusion, using infusion pump is safer, as it avoids human error in administration of a higher dose. But infusion pumps, unfortunately, these are expensive, and that is the reason these are not available at low resource settings. One infusion pump is costing around rupees 20,000. RCOG 2023 recommends this regime that is called as collaborative eclampsia trial regime, where instead of 4 to 6, they have given 4 gram as the initial loading dose slowly over 5 to 15 minutes, followed by not 1 to 2 gram, but 1 gram per hour. So that is the difference between the dose which has been recommended by Williams Obstetrics and this RCOG. That RCOG is advocating a lower dose, not a range of 4 to 6 or 1 to 2, but only 4 gram as loading and 1 gram per hour. It should be given, if it is given prophylactically severe preeclampsia, it should be given only for 24 hours. And if it is given when patient has conversion, it should be given for 24 hours after the last conversion is the recommendation. Now, when do you give it a severe preeclampsia is only when delivery is expected in the next 24 hours is the most important point in the guideline by RCOG, that you don't give when you are planning the expected management for severe preeclampsia. You give it whenever you know that you need to terminate the pregnancy in next 24 hours. Reason is prolonged use leads to, suppose you give and then you stop after 24 hours and again you give after a safe 1 or 2 days. What will happen is it will lead to prolonged use, and prolonged use leads to neonatal skeletal adverse effects, especially bone thinning and fractures are seen in the neonates if it is given for more than 5 to 7 days. If magnesium sulfate is given for more than 5 to 7 days, it is going transplacentally into the fetal circulation. It leads to hypermagnesemia and hypocalcemia, which leads to bone thinning and risk of fractures in the neonate increases. If there is a repeat conversion after you start this regime, what you do is you give either 2 gram or 4 gram IV, 20% IV slowly to be given, or you add it to 100 ml and give slowly if there is a repeat conversion. You can either add it to 100 ml of normal saline, or it can be prepared as a 20% solution to be given slowly, either 2 gram or 4 gram. Intramuscular Maxwell regime is called as Pritchard regime, where you give 4 gram magnesium sulfate IV intravenously as a bolus, 20 ml, 20% to be given over 5 to 15 minutes. Then you give 10 gram deep intramuscularly, 5 gram in each buttock in the outer upper quadrant of the buttock. It should be given. So total loading dose in this Pritchard regime is 14 grams, where you give 4 gram IV and 10 gram intramuscular. To give intramuscular, we have to use 3-inch long needle. 20 gauge needle is to be used, and we can add 1 ml of 2% lidocaine to this magnesium sulfate to reduce the pain, because we know that these are painful injections likely to produce induration or rarely abscess also. But this intramuscular regime is as effective as intravenous regime. Efficacy is same as IV regime. But only disadvantage is these are painful injections. That is why many developed countries have shifted and stopped using this Pritchard regime, and they have shifted to continuous intravenous administration. After giving this loading dose of 14 grams, then you give 5 grams every 4 hourly in alternate buttocks. Provided what you ensure is there is a presence of patellar reflex, respiratory rate is more than 14 per minute, and urine output in last 4 hours is more than 100 ml. This regime is continued for 24 hours after the last conversion or after delivery, whichever is later. IV intermittent regime is where it is loading dose is given as 4 to 6 gram, 20% or diluted in 100 ml, and it is given slowly over 15 minutes. Then 1 to 2 gram is again added to 100 ml of normal saline or ringer lactate, and then it is to be given every 4 hourly intravenously. That is also given slowly over 15 minutes, and along with that careful monitoring is mandatory. Now, what postgraduates need to remember, if you are asked how much is a dose magnesium sulfate used for therapeutic dose of magnesium sulfate in patients of eclampsia, and what is a dose prophylactic dose of magnesium sulfate in patients with severe preeclampsia and hypertension in pregnancy, your answer should be the dose is same. It is not that for severe prophylactic action for severe hypertension in pregnancy, you give a lower dose, and for eclampsia, you give a higher dose. That is many times that is a misconception, and that is why I have included this slide especially to stress on this point, that whether you are using it as anticonvulsant, as therapeutically or prophylactically, the dose of the therapy is same. Duration is also for 24 hours. For eclampsia, it will be after delivery or after the last conversion, whichever is later, whereas for severe preeclampsia, it is for the total duration of 24 hours. So many times it happens that you have initiated the therapy, given a loading dose and started on maintenance dose, and still there are repeat conversions, which are seen in around 15% of the patients of eclampsia. In that case, either you give 2 gram, 20%, that is 10 ml to be given slowly intravenously, or what you can give is 4 gram as 20%, 20 ml, especially in patients who are obese. Then you repeat the dose as 4 gram. In a small woman, you can repeat it to the dose by using 2 gram of magnesium sulfate. In spite of using the full dose and in spite of repeating the dose, if there is a persistence of conversion, which all of us must have seen once or twice in our career, that there are rare cases where the patient doesn't respond to Maxulf regime in spite of using the full dose and in spite of repeating the dose. That is rare. That is seen in around 2% of the women patients with eclampsia. In that case, what is advocated is addition of a short-acting benzodiazepine such as midazolam or lorazepam should be given intravenously, for which we can take the help of our anesthetic friends. It should be given for a short duration as there is a risk of aspiration pneumonia and even maternal death if it is given for a longer duration. RCOG says that use of other anticonvulsants such as diazepam, phenytoin is not indicated whenever we are using magnesium sulfate, as it leads to the additive risking leading to even serious maternal morbidity or mortality. How do we prepare 20 ml? 20% magnesium sulfate is a commonly asked question even to undergraduates, and as a postgraduate, it is a must know question. As you don't know or you can't answer this, you can't pass your exam. So what you take is 4 vials of magnesium sulfate is equivalent to 4 gram of Maxult, that is 8 ml. Each vial is having 2 ml, so we are taking 8 ml of 50% magnesium sulfate. Then we add 12 ml of distilled water so that we get a solution 20%, 20 ml solution of magnesium sulfate. On the other hand, if we want to prepare a 2 gram, 20% Maxult solution, we take 2 vials is 2 gram, that is 4 ml of 50% magnesium sulfate. It will be containing 2 gram of magnesium sulfate, 4 ml, and we add 6 ml of distilled water so that what we prepare is a 10 ml of 20% solution of magnesium sulfate containing 2 gram. It is specially for required if there is a repeat conversion in spite of giving a full dose of magnesium sulfate therapy. What is the effect of magnesium sulfate on fetus or neonate? It leads to reduction in bit-to-bit variability and reduction in sometimes baseline fetal heart rate also, but this action is a transient action. There are as such no serious adverse effects in the fetus or neonate in majority of the cases. But if there is a hypermagnesemia, if maternal serum magnesium level is high at the time of delivery, it is more than therapeutic level, more than 4 to 7 milliequivalent per liter. In that case, there can be neonatal hypotonia, there can be increased need for intubation and ICU admission in neonate. So if there is a hypermagnesemia, then what are the effects are neonatal hypotonia, increased need for intubation and ICU admission. If magnesium sulfate is given for a prolonged duration, more than 5 to 7 days, it leads to skeletal problems as we have already discussed in the previous slides. It leads to hypocalcemia, hypermagnesemia, bone thinning, and increased risk of bone fractures in the neonate. What are the advantages of this drug as an anticonvulsant over other anticonvulsant drugs such as phenytoin, or we used to give Krishna Menon regime or diazepam? It is an effective anticonvulsant without CNS depression. Patient regains consciousness 1 to 2 hours after initiation of treatment and remains alert and cooperative throughout treatment or throughout the delivery. There is a decreased rate of repeat conversions as compared to diazepam or phenytoin, least maternal mortality rate as compared to other anticonvulsants, and it is safer as compared to other anticonvulsants for the fetus and neonate. So that is the reason it is the drug of choice in patients of eclampsia to be used as an anticonvulsant therapy. Now, this is most important sentence in today's class, that magnesium sulfate is a life-saving drug but has life-threatening side effects. Why monitoring is a must during Maxulf therapy is it is mandatory to avoid magnesium toxicity, because magnesium toxicity leads to respiratory arrest followed by cardiac arrest. Now 90% of the maxill gets excreted by kidneys. Magnesium sulfate toxicity risk is higher whenever there is a impaired renal function. Serum creatinine level more than or equal to 1 milligram per dl indicates impaired renal function, and it is a risk factor for magnesium sulfate toxicity. It is mandatory to monitor such patients by serum magnesium estimation on 4-hourly basis whenever the serum creatinine level is more than or equal to 1 milligram per dl. How do you monitor a patient on Maxer therapy? You all postgraduates, you all must be doing on almost frequently or daily basis this monitoring, but whenever you are asked in examination, sometimes you fumble, and that is why it is an important slide for us. There should be presence of deep tendon reflexes or patellar reflexes. Absence of patellar reflex indicates toxicity. Urine output should be at least 30 ml per hour. Anytime it is less than 20 ml per hour is an indication to stop magnesium sulfate administration. Respiratory rate should be more than 14 per minute. Oxygen saturation is a very good indicator of respiratory health of the patient, and anytime it should be more than or equal to 96%. It is the earliest indicator of respiratory depression whenever it falls to less than 96%. So whenever a patient is on Maxell therapy, pulse oximeter should be used. Serum creatinine should be less than 1 milligram per dl. So we need to do the serum creatinine estimation as a baseline, and it should be repeated anytime if urine output is less than 30 ml per hour. Serum magnesium level should be 4. Therapeutic value for anticonvulsant action is 4 to 7 milliequivalent per liter. This monitoring should be done on 4-hourly basis. 4-hourly monitoring is a must. Monitoring for these features of magnesium toxicity along with maternal pulse and blood pressure and fetal heart rate. What is the indication to monitor Maxell therapy by serum magnesium level? This is the question if you are asked. In which patients you use the serum magnesium level to monitor the patient on Maxell therapy so that to prevent Maxell toxicity. So in this case, your answer should be it is not required as a routine in every case, but it is required whenever there is an impaired renal function. Urine output is not the best indicator of renal function. Serum creatinine is more reliable. Serum creatinine level more than or equal to 1 milligram per dl indicates greater risk of Maxell toxicity. It needs monitoring in this case, monitoring needs to be done by serum magnesium levels. We need to know the time whenever we are using this magnesium sulfate therapy, and whenever creatinine level is, if say more than or equal to 1 milligram per dl, we should be sensitive about how much time is required for our setup to get the report of serum magnesium from our lab. It should be as less as possible. Say you are sending the sample for serum magnesium and you are getting the report after 4 hours. Already there might be further deterioration of hypermagnesemia which might be missed, and that is the reason the lab should be giving us the report at the earliest within an hour at the most. We need to know the unit in which the serum magnesium reporting is done. That is another point I want to stress. Why serum creatinine is a better indicator of renal function as compared to urine output? Magnesium clearance is dependent on glomerular filtration rate, GFR. In case of renal failure, urine output sometimes increases whenever we are using diuretics. Transiently, there is an increase in urine output. But remember that magnesium clearance or excretion remains low in spite of increasing urine output if there is a reduced GFR. That is the reason serum creatinine is a better indicator of GFR, glomerular filtration rate, and overall renal function as compared to the urine output to detect the patients who are likely to be at a greater risk for magnesium sulfate toxicity. Whether serum creatinine is a must before administering loading dose of magnesium sulfate. Whenever you get a patient of say eclampsia or severe preeclampsia and you want to use magnesium sulfate, whether you need to send a blood sample for serum creatinine wait for the report of serum creatinine and then only to start the therapy? Your answer is no. For loading dose, it is not required. The reason is when you give the loading dose, for initial first hour, there is a hypermagnesemia. That is, level will be more than therapeutic level, more than 4 to 7 milliequivalent per liter. But then the magnesium sulfate enters into the cell, intracellular entry of the maxil, as well as clearance by the kidneys, that leads to the stabilization of the dose in the therapeutic level. And that is the reason the risk of maxil toxicity is less when we give the loading dose. But whenever we give the maintenance next repeat dose or continuous IV administration, that is to maintain the level in the therapeutic range. For that, we need what we need is a serum creatinine level. So serum creatinine level is mandatory to decide the maintenance dose. It is not, that is before you, when you start the IV continuous IV administration, you need to adjust the rate of that continuous IV administration dependent on the serum creatinine level. Or you are giving intramuscular, then also you need to be cautious and you need to reduce the dose of intramuscular administration, or you can even increase the interval. Rather than 4 hourly, you can say you can use it 6 hourly if the serum creatinine level is more than or equal to 1 milligram per dl. So in that case, you reduce the dose as per serum magnesium level. This is an indication for then administering the next dose dependent on serum magnesium level. Increase the creatinine, serum creatinine is a must whenever we are keeping the patient on maintenance dose of maxil therapy. Raised serum creatinine level is an indication to monitor the patient by doing a serum magnesium level. Now, in the serum magnesium level, this is most important. We should all be knowing all these values by heart. And as I said, left hand side shows milliequivalent per liter, right hand side shows milligram per dl. So whenever you are you see a report of serum magnesium in a patient on maxil therapy, first thing what you should see is what is the unit in which your lab is providing you the results. Like we always, whenever I was working in my career, I have always seen the reports in milligram per dl. So whether lab is giving in milligram per dl or milligram per liter, because here the values are slightly greater whenever we are it is given as milligram per dl. Therapeutic level is 4 to 7 milligram per liter, whereas it is 4.8 to 8.4 milligram per dl. First feature of magnesium sulfate toxicity is absence of patellar reflex and or deep tendon reflexes, and it occurs at 7 milligram per liter, whereas it occurs at 9 milligram per dl. Respiratory depression is observed whenever the value level is 10 milligram of 10 milliequivalent per liter or more than that, or 12 milligram per dl. Cardiac arrest will occur at 25 milliequivalent per liter or at 30 milligram per dl. So it is important to see the unit while reading the report and interpreting the report from your lab. What is the effect of maxil toxicity on myometrium? There is a uterine muscle relaxation whenever there is a 8 to 10 milligram per liter is the value. And in these cases, there is increased risk of prolonged labor as well as there is an increased risk of atonic postpartum hemorrhage. Now, whenever a patient is taken on for cesarean section and she is on maxil therapy, what you should remember is if general anesthesia is to be given, the need for the muscle relaxant, the lower dose of muscle relaxants will be required because there is a synergistic action of magnesium sulfate and muscle relaxants. Your anesthetist will be aware of this, will be using a lower dose. And if the higher dose is used or usual dose is used, patient might not be coming out of anesthesia at the end of surgery and might need a mechanical ventilation for a few hours till the magnesium sulfate gets cleared off. Now, I have included these important definitions of preterm labor as per given by NICE 2022. Now, this is RCOG, as I have already said in my previous lectures. RCOG is a body, Royal College of Obstetrics and Gynecology from UK. which is providing certain guidelines, and NICE is a body which is a government of UK, England, and that is giving certain guidelines, and these guidelines are that is a both of these. Remember that RCOG and NICE, both the guidelines are from England, from UK. So accordingly, according to this NICE guideline 2022, these important definitions are given as far as preterm labor goes. And I thought that this we should all know whenever we are dealing with a patient where we have to take a decision whether to give magnesium sulfate in patients of preterm labor. Suspected preterm labor is when there are symptoms of preterm labor, that patient has pain in abdomen, and there, with that sterile per speculum per vaginal examination also is suggestive that patient is in labor, but she is not in established labor. That means cervical dilatation is there, some effacement is there, but dilatation is less than 4 centimeters. What is diagnosed preterm labor is there are features of suspected preterm labor, and along with that, transvaginal sonography shows cervical length of less than 15 millimeter. If patient is not willing for transvaginal sonography, then the NICE guideline recommends that you go for fetal fibronectin test if it is available. And if that test is positive, where the fetal fibronectin level is more than 50 nanogram per ml, that is also indicative of a case of diagnosed preterm labor. So if we don't do the transvaginal sonography or fetal fibronectin, then what is your diagnosis is a less than 4 centimeter. It is a case of suspected preterm labor. And if it is more than 4 centimeters and it is a progressive dilatation with regular uterine contractions, then you say that patient is has a established preterm labor. So writing only preterm labor is incorrect. You need to say whether your patient is a case of suspected, diagnosed, or established preterm labor. That is for postgraduates. So remember that these are the three terminologies you should be knowing. And accordingly, whenever you write the diagnosis in file, whenever you diagnose a patient of preterm labor, you must mention whether it is a suspected preterm labor, diagnosed preterm labor, or whether it is a established preterm labor. The reason is, whenever we use magnesium sulfate for fetal neuroprotection in preterm labor, as per NICE 2022 guideline, it should be used only when there is a established preterm labor. So it is not used in suspected preterm labor, it is not used in diagnosed preterm labor, but it is only used in patients of established preterm labor, where I will repeat that, where there is a preterm labor with a progressive cervical dilatation of more than 4 centimeters with good uterine contractions, then only it is called as a case of established preterm labor. And in these cases, you are supposed to decide whether to give magnesium sulfate for fetal neuroprotection, or if there is a planned delivery in next 24 hours, then you consider use of magnesium sulfate for fetal neuroprotection in preterm labor. Now, if the patient's gestational age is 23 to 24 weeks, you discuss and decide. The reason is the possibility of fetal survival will be dependent more on how our facilities, NICU facilities are there, how pediatric support is there, and that is why you discuss and decide whether to give it in these cases. But you should offer it whenever the gestational age for a patient of preterm labor is between 24 to 29 plus 6 or 30 weeks. After 30 weeks, up to 34 weeks, again you consider whether to give, you weigh the advantages and disadvantages of Maxwell therapy, but it is not that you should not be giving. You can consider it up to 33 plus 6, that is up to 34 weeks also we can consider, but we should definitely offer magnesium sulfate as for fetal neuroprotection from 24 plus 0 to 29 plus 6 weeks. Similarly, for PPROM, that is preterm pre-labor rupture of membranes, you offer from 24 plus 0 to 29 plus 6 weeks, 24 to 30 weeks, provided again, what is most important is delivery is expected in 24 hours, or patient is already in established labor where there are good contractions with cervical dilatation of more than 4 centimeters. How it is given is, it is given for fetal neuroprotection. Mainly it reduces the incidence of cerebral palsy, and that is why it is used. It is given as 4 gram IV, 20% diluted, or it is added to 100 ml of normal saline or ringer lactate solution, and it is given over 15 minutes. And then continuous infusion to be given as 1 gram per hour. This should be continued till delivery or for total duration of 24 hours, whichever is earlier. Patient fails to deliver at the end of 24 hours, you don't continue, you stop after 24 hours, or patient delivers say after 8 hours, you stop, and it should be given along with careful monitoring. Should magnesium sulfate be used as a short-term tocolytic, where you want to either ship the patient from one place to the other for a better neonatal facility, or you want to give steroid, or you want to have the action of magnesium sulfate as a fetal neuroprotector? And for these three indications, we are using tocolysis as a short-term tocolysis. There is no long-term tocolytic use in obstetrics. These are always given as short-term tocolytics. Long-term tocolytics were used in the past, but these are no more being advocated. But magnesium sulfate, if it is given for tocolysis, higher dose is required, where possibility of maximum toxicity keeps on increasing. It is ineffective in a lower dose. Or as such, if you compare with other drugs, it is less effective, and that is why ACOG clearly says that it is a drug which is ineffective as a tocolytic. It has serious potential side effects, and that is why nifedipine is the drug of choice. If nifedipine is contraindicated, what all the guidelines are now advocating at present is use of oxytocin antagonist, that is atosiban. But atosiban, unfortunately, is expensive. If you see the total cost required for the use of atosiban in single patient, it is around rupees 45,000 approximately. Magnesium sulfate should not be used as a tocolysis as per NICE 2022 guideline. If there is a nifedipine is contraindicated, we can try ritodrine, we can try terbutaline, we can try indomethacin, and comparatively magnesium sulfate is found to be less effective as a tocolytic, and possibility of side effects is more. Now, if magnesium sulfate and nifedipine, should it be used? If whenever we are giving it, suppose in a patient, patient is from 24 to 30 weeks. With preterm labor, we are giving already magnesium sulfate for fetal neuroprotection. But with that dose, there is persistence of uterine contractions. Then in that case, we need to add another tocolytic. So which tocolytic to be added? Can we add nifedipine, terbutaline, ritodrine? Remember that all these drugs have increased risk of maternal complications when they are given along with magnesium sulfate. So the drug which is safer is indomethacin. And in spite of that, though it is safer, it needs careful maternal and fetal monitoring whenever it is being given along with magnesium sulfate. What should you check on daily basis in emergency area whenever you want to use magnesium sulfate in emergency? Adequate availability of max sulf ampoules to be checked on daily basis. You need to check how much is the concentration of magnesium sulfate in ampoules, because I have seen 25% ampoules in my career. So you need to ensure that the ampoule has 50% of magnesium sulfate. If it is 25%, your preparation will entirely change, and where one ampoule will be having only 0.5 gram, and you need to use more ampoules, and it is not that you can't use, but the amount of distilled water which will be used will be drastically reduced in that case. Infusion pump, if it is there, whether it is in functional state, that should be ensured. Calcium gluconate or calcium chloride should always be in the emergency trolley. Whenever 1 gram should be available, 10% 10 ml is given slowly over 3 minutes and should always be available in the emergency trolley. See to it that it is available, and you needs to check expiry date also, because these are less commonly used and sometimes the drug is available, but the expiry date, when if you check it, you see that it has already expired. So you need to be careful about that. Intubation and ventilation, mechanical ventilation facility should be available, and trained personnel should be there. Always presence of a anesthetist, if required, should be ensured. Facility to get timely report of serum creatinine and serum magnesium level. That makes the use of magnesium sulfate therapy safer for us. If we want to give intramuscular therapy, then 3-inch long 20 gauge needle also should be available. Why there is no tocolytic action or atonic PPH when patient is on anticonvulsant magnesium therapy? That is commonly asked question in examination. Why don't you see that whenever you use magnesium sulfate therapy in patient of eclampsia, you also induce the labor simultaneously in so many times. So why there is no tocolytic action? Why there is no atonic PPH? Your answer should be therapeutic serum magnesium level for anticonvulsant action is 4 to 7 milliequivalent per liter. Tocolytic action is at 8 to 10 milliequivalent per liter. So higher dose is required for tocolysis. There is no problem for induction of labor with this anticonvulsant dose, and there is no risk of atonic PPH with this dose. That should be your answer. If there is a magnesium toxicity, how will you deal with that? Discontinuation of magnesium sulfate. If it is continuous intravenous, then you stop the IV drip. If intramuscular, you stop giving subsequent injections. Calcium gluconate or calcium chloride is to be given 1 gram intravenously as 10 ml 10% solution over 3 minutes it should be given. Now, effect of these drugs is unfortunately short lasting, and if there is a severe toxicity, one has to proceed with intubation and mechanical ventilation, which will prove to be life-saving in these patients having a respiratory depression because of magnesium sulfate toxicity. When not to initiate magnesium sulfate therapy in preeclampsia, preterm labor, or PPROM? When will you not be considering magnesium sulfate in these uh, conditions? Your answer is whenever the patient is for expected management in a patient of severe hypertension in pregnancy, or even in a patient of preterm labor or PPRM, whenever you want to go for expected management, whenever you want to continue the pregnancy for say another 1 week, then these are the cases where you do not uh, use magnesium sulfate. Thank you so much.